So my name is Dr. Ariciment. I had a radial nerve injury back in January 12th, 2024. And, there really wasn't a lot of guidance. It's a rare complication. And I said to myself, if I get better one day, I definitely want to share my experience because maybe it will help even one person down the line. And it might help actually some practitioners too. Who knows? So here goes. So I'll go through my injury and then I'll really focus on the medical aspects and from the patient's perspective as well. So on January 12th, 2024, basically I fell down. I was playing tennis and it was 12-12, whatever. My friend hit it into the puddle by accident and I jumped for it and I fell back and my left hand was caught underneath the back, almost like I was like handcuffed, and I fell on it, snapped the bone, mid-shaft humerus fracture. If you want to classify it, I guess it would be a type A transverse fracture, A3, according to the Orthopedic Trauma Association, if you want to classify it. So when you have a humerus fracture, it's type A, B, or C. You can see if it's wedge fracture or complex fractures, typically like, trauma in the car accidents, they're going to have more complex fractures typically, or gunshot wounds type of thing. Mine is really a type A transverse fracture. The problem, as you'll see, is that I had on the next slide. Clearly in the emergency room, you can see the bone was jutting out. I was in a lot of pain actually, but the truth is I had a palsy right away. I could not feel or move my left hand, almost like, when you fall asleep on your arm. It's exactly that, where your hand is basically like this. It's called a radial nerve palsy. They say it happens in about 15% of midshaft humerus fractures, typically self-limited, 3 months typically. But that was the tricky situation here because you don't know. And the question is, should you have early surgery, or should you wait? Early surgery within 2 weeks or right away if it's really complex? Obviously, if there's an open fracture, you're going to probably go to the OR. It was Martin Luther King Day weekend. So that was January 12th, and I was scheduled for surgery January 15th, mostly because I was pushing for it because I had complete radial nerve palsy with the injury. So if it's just a humerus fracture by itself, it could heal on its own. There's a special brace which they put on me in the emergency room called the Sarmiento brace. They actually initially tried to reduce in the ER, and they also gave me a what's it called when they put the nerve block, right? They did a nerve block, ultrasound guided brachial plexus nerve block, which actually helped me for a couple of days. They injected steroids. It helped with the pain. But then they put a Sarmiento brace, which is a type of brace which allows you to move a little bit. And honestly, it was the worst 2 days of my life for sure. You could feel the bones crunching against each other, knowing that there's probably a nerve inside there. It's really uncomfortable. I would say that if you have a friendly surgeon, honestly, if you have a midshaft humerus fracture, you're calling up that surgeon, you're calling up that favor, and you're trying to have surgery as soon as possible. That's my own opinion. Again, with radial nerve injury, meaning radial nerve palsy, I don't see why you would wait a couple weeks, even though they say even early surgery is within 3 weeks of injury. Um, I would say get on the phone with a nerve surgery, not a trauma surgeon per se. I think the nerve experts are probably better to do this type of surgery because they have more attention to the actual nerve. So in other words, there are trauma surgeons out there who are awesome, and there are nerve surgeons who I think are more suited to do this type of surgery if there's radial nerve palsy with a humerus fracture. So just so you know the terminology, the nerve could be either like on the side of the bone, and it could be just, some of it could be lacerated, but not fully lacerated, or it could be contused, as it was in my case, or it could be entrapped. And then as you release it, could get lacerated, or it could get trapped further. Remember, you're prodding and moving, and all these things can happen during surgery as well. So my specific surgeon happened to be an expert in the nerve, Stephanie Shim. She was able to locate that the nerve was actually entrapped, which happens about, I think, around 5 to 10% of these cases. So again, bad case scenario, but it could have been worse because it could have been lacerated. And she was able to unentrap it, and you could see the very big scar that I had. But more importantly, she put a very large brace, making sure that the bones were opposed to each other and that the nerve is, of course, free. That was great that it was contused, and then you're hopeful that maybe you should have a recovery. When the radial nerve is damaged, you basically have Wallerian degeneration, and then part of that process is regeneration. So it's essentially the axon of the nerve degenerates, the myelin sheath, which makes up part of the nerve, dies, breaks down, and then there's phagocytosis. It gets eaten up, Schwann cell response. You want active Schwann cells, and then you want regeneration of the nerve. So going from the site of injury all the way back down, like the radial nerve is injured at the humerus, and you want to see it, Schwann cells regenerating 1 millimeter a day, and hopefully you get regeneration. You don't want a neuroma to develop, which is a part that could develop in the nerve that can block the regenerative process, and that's something that you might want to get an ultrasound to take a look at later on to rule out a neuroma that's developed. When the radial nerve is damaged, basically. One thing I certainly was not prepared for was the swelling post-op. It was insane, and it lasted me about 7 to 10 days. So just because you have your radial nerve released, it's not over. And in fact, I really was convinced that I had a compartment syndrome, and I didn't, but I was convinced that I had one. So here's what you can do. You could elevate above the level of the heart, which I didn't do the first day, which I should have known as an ICU doctor. Then you need to apply ice packs intermittently, 20 minutes on, 20 minutes off. That I did do, 48 to 72 hours. I actually bought a few of those like compression ice things, and it seemed to work. Compression, you could use a compression bandage, well-fitted splint, mobilize the fingers to move around stuff, and then, check your pulses. I really turned blue, but I made it through. That rhymes. One thing I certainly... Here we go. I'm going to take this off just to show Mark what I'm up to. So here, it looks good. Still complete wrist drop, right? But I could do this, and then watch what else I could do. Lift up the hand all the way up. I'm like Karate Kid, like Karate Kid, karate chop, like that guy, but not purposely. It's like the movie Karate Kid, but okay. But anyway, I was trying to be funny. And I go like this. I can move it up, no problem. Like so, here I'm going to demonstrate how to use a radial nerve brace, which is really important so that you keep the wrist from dropping, because the natural tendency is for the wrist to go down with gravity. So this is a radial nerve splint. Okay, so you put the fingers in like this, and then you put each one of these guys on. It took me a while to learn how to do this, so that's why I'm showing it to you. You go like this, so now it's like that, and then you put this part. It always gets Velcro problem. Thank God I haven't done this in a while. Then you put this like this, and then like this. The idea is, now some say that if you keep your arms supinated, it might be better for nerve reconstruction or recovery, whatever. I don't know if I believe that, but so I don't know. You could look that up. But here, it prevents the arm from going down. It gives you air. And actually, I did bronchoscopies using this. My thumb was dead too, so I had to get you can get a Velcro here and put around the thumb to keep it up. That was also key, and it allowed my arm to feel the air, and that was really crucial in making me more sane. So I recommend that you get right away a radial splint brace. These are $50 on Amazon. So as a doctor, I sort of wanted to know what was happening at the nerve level. You might not be interested in this, but I think it might help you. So the radial nerve is what innervates the muscles of the forearm that keep your arm, your hand up, right? So the key muscles later on are the brachioradialis, okay, the extensor carpi radialis longus. Okay, the brachioradialis goes like this. Basically, the ECRL and ECRB, extensor carpi radialis brevis, will keep your arm up. Okay, the supinator later on is the muscle that helps keep your palm up, from down to up. And then you have the extensor muscles that move your fingers up, and then the abductor pollicis longus and extensor pollicis brevis. And so then the very last thing to expect is your thumb, okay, and your finger, and actually your index finger. Those are the very last things. So don't expect that at all. The very first thing you want to see is the brachioradialis, okay? So there's also another issue, specifically what I had, which was posterior interosseous nerve injury, a secondary likely injury as well. So if you're unlucky enough to have what I probably had, which was a stretch injury at the posterior interosseous nerve, then you could get the brachioradialis and the extensor carpi radialis longus back. So you could lift up your wrist a little bit and you could hammer, but then you won't get your fingers. So you could have that as well. And I do recommend getting an ultrasound a couple weeks, maybe 3 weeks after surgery, to take a look. First of all, to make sure the continuity of the nerve is okay, and also to see if maybe there's a secondary stretch injury. A lot of the surgeons do not do that, which is fine. But in my case, I think it really did help. Also, what's really key with this slide, which I didn't highlight, is that notice the brachioradialis is 10 centimeters away from the site of injury in the midshaft humerus fracture. So remember, a millimeter a day is like when the nerve is dead, it has to regenerate. So typically, when they say this 3-month thing, it's true that it seems like in the studies, as you'll see, 3 months typically people do get, if it's just a straight up radial nerve palsy. But a lot of times 3 months is when you start to see. So 10 centimeters is 100 millimeters. That's 3 months, 3 months and some before the nerve travels from the site of injury to the brachioradialis. So then extensor carpi radialis longus is 2 centimeters away from that, which is 20 millimeters, which is 3 more weeks. It takes forever. Okay. Extensor carpi radialis brevis is 8 centimeters away from the brachioradialis. That's 80 days. Okay. That's 80 days away from the brachioradialis. So you're going to have to be patient. You're going to have to wait. And that's just the reality. So here I want to reiterate, when it says the time to onset of recovery in these studies are like 2 months and then 5 months to the onset of full recovery. So remember this, the onset of recovery, you're not going to be much different than most people. The onset of recovery is 2 to 3 months. That means you might start seeing in the brachioradialis something. So you might see a little flicker of a muscle, but it doesn't mean you're going to be moving and shaking and baking, okay? 5 months is when you could expect, hopefully, if everything goes well. So, and there's a difference between, remember, we went over the types of fractures, A1, A2, A3. If it's a simple A1 fracture and a radial nerve palsy, yeah, maybe you'll be fine in 3 months. But if you have a C1 like I did, don't expect any onset of recovery for a while. And the time to full recovery, as you can see in this one, was 35 plus or minus 2 weeks, which is what, 37 divided by 4 is what, 9? So it's like 9 months. And so you could measure your site of injury to the brachioradialis. So mine was 175. And so I divided by 7, 25 weeks, 6 months is when I should start to see the BR firing. And that's precisely what happened. I was very, surprised that it took so long, but I really should not have been. So right after surgery, I had severe edema, as we mentioned, and then I just basically was measuring my injury to see how far the muscles were from the nerve, and then realizing that, my gosh, this might be longer than I anticipated.
So here's my hand.
Here's the hand.
Still got the wrist drop, obviously.
Can you see it?
The rest of the hand looks.
Couldn't move
I
the
guess
whole
that's
thing.
the
Just,
video.
you know.
So here's my hand.
All the way up.
Still got the wrist drop.
So unfortunately, there is a painful aspect. It's not like sharp pain, but there is like spasmy type of numbness and tingling, and definitely pain. Especially there's some cold sensitivity. Unfortunately, 3 to 6 months, it's really bad. I mean, I'm a year out, and I still have some weird pains occasionally. But so there is an aspect there on the thumb. You can see the yellow over there in March, and the red over there. That's where I was really having pain and just a weird feeling. It took me about 4 minutes to put on a surgical glove, and I had to do, for procedures. This is just a representation of some of the injury that you could expect from a radial nerve. I think the other part is that you're going to be complaining, and people are going to find you a little bit annoying, and just recognize that's part of the process. Here's a great overview of somebody who has a humerus fracture and radial nerve injury. You're going to want to be treated with an operation if you have a radial nerve palsy within, I would say, within the first 3 days, and you don't want to look back and say, oh my god, I waited 2 weeks and now look what happened. I would, that's my opinion. Again, if it's cut, if the nerve is lacerated, well, you might go straight for a tendon transfer, potentially a nerve transfer early on. If it's contused, or certainly if it's continuous, you're going to wait. But if it's contused, you're also going to wait. Usually, you're going to wait 3 months. In the meantime, at 1 month, you're going to get a baseline EMG and an ultrasound. I would recommend that you get an ultrasound to rule out a neuroma. And then at the 3 month mark, you're also going to get an ultrasound and EMG. An EMG is more important than the ultrasound. Some of the best surgeons in the world will not even look at ultrasounds. I've come to understand, which I'm really surprised at in this day and age. And then within 6 months, you're going to have a nerve transfer or a tendon transfer. Some places do tendons so well, and we'll take a look at that, they might offer it even earlier. But you really want to see some sort of recovery by the 3 month mark. So if you don't have it, you're going to probably have a secondary exploration planned. You certainly are going to have been seen by a nerve expert or tendon transfer expert. So here, if you could follow, this is an illustration of what a nerve transfer is. So basically, you have the radial nerve up on top and the median nerve right underneath. Those are two healthy nerves, no problem. And look on the bottom, you can see the radial nerve is now cut. There's a hole in there. So you need to get to the, let's say, extensor carpi radialis brevis. How are you going to get there? With a supinator, how are you going to get there? So you do transfers from the median nerve that is healthy, and you bypass that area that is cut. The downside with the transfers is that you have to wait potentially 6 to 12 to 18 months to see if it really has worked. So just like you've waited this whole time to see if your radial nerve is alive, now you have to wait to see if your transfer works. So for people like me that are a little impatient, that's not going to work for me, unless you know that you're gonna wait. Nerve transfer on the upside is that you don't really have to do physical therapy as much afterwards, because you have the same natural movement and the same mobility potentially with a nerve transfer. So the advantage of a nerve transfer is that you can have better mobility. The disadvantage is that you have to wait a long time, and you're not sure if it's going to work. So I tend to favor a tendon transfer, but nerve transfer, if you catch it, also you have to catch it early enough before the end plates, the motor end plates of the muscle die. So you can't think of this 12 to 16 months after the injury. You have to think of it basically within the first 3 to 6 months. You have to see somebody within the first 3 months, basically, and map it out, or 6 months. And then, but you really probably can't do it after 9 to 12 months, I think the surgeons will tell you. So tendon transfer becomes the only option later on. So now we're going to talk tendon transfer. Basically, we're going to talk on the next slide a little bit more in detail, but basically you're taking a tendon that normally did a different function. So the pronator teres used to pronate. It used to do this. So now when you do this in your mind, it's going to be doing this. So you're going to have to train your brain that, hey, guess what? I'm not doing this anymore. It's doing this. So that's tricky you're going to need some physical therapy when it comes to tendon transfers. That being said, you're also going to have some muscle atrophy with tendon transfers over nerve transfers. So another advantage potentially of nerve transfer over tendon transfer is that you potentially will not have as much muscle atrophy with nerve transfer. So now we're going to talk next. We're going to talk about tendon transfer. I think one of the main gurus in the world, as I did a lot of research, is Alex Shin at Mayo Clinic. I consider him a friend. He was there for me emotionally and helped with my pin compression syndrome surgery later on. He's really a great person, has many students like Andrew Lovey, who was my surgeon for the pin decompression, and Mayo Clinic is where I would recommend you to first think about if you have an injury here. And specifically Alex Shin. Tendon transfer used to treat radial nerve palsy is the pronator teres to the extensor carpi radialis brevis. That will restore wrist extension. Then there's a flexor carpi ulnaris to the extensor digitorum communis. That will help with the finger extension. And then the palmaris longus to the extensor pollicis longus, which will help you restore thumb extension. Now, 15% of people will not have a palmaris longus. Of course, my injury was in my left hand, and I did not have a palmaris longus. Ironically, I had one in my right hand, so I would not have had a palmaris longus to use. But then they could do a split finger or whatever they call it, whatever. They could figure out what to do. It's not as ideal. So depending on your anatomy will depend on whether or not you can get an ideal tendon transfer. But Mayo Clinic people or people that have done tendon transfers will figure it out. It is considered more of end of line again, but some people will do that first because it has very good functional um, capability, anatomic, biomechanical suitability, and it really does make sense if you really want to get back to yourself or a remnant of yourself again as fast as possible and not have to wait. The downside is that you do have to go to physical therapy about a month and a half after because those muscles, the pronator teres, flexor carpi ulnaris, those are median nerve innervated. So it used to be flexors or whatever. Now are extenders. You got to retrain your arm how to do that, and that takes a little while. Most of the time, I'm going to show you the progression of my injury and what happened. But my case was a little bit more complicated because I had a potential compression at the posterior interosseous nerve, which is a break off of the radial nerve after it passes through the elbow, and that's after the extensor carpi radialis. As long as for those that don't understand, it doesn't matter. It's just a separate issue. This is just to show you what an ultrasound would look like and how important, in my case, potentially, the ultrasound did demonstrate that besides the fact that my nerve was continuous, which gave me good peace of mind, it did show a potential stretch injury, a secondary injury, which is, some surgeons thought it wasn't, others thought it was, at the level of this thing called the arcade of Frost. Anyway, ultimately, I did need surgery, but the point here is really to show you the value of getting an ultrasound, probably at the 1 month and then the 3 month and then thereafter. Whoever you are, unless you're a hand surgeon, you're really not an expert. So you want to follow what they say. Usually it's an EMG, a nerve conduction study, at 1 month and 3 months. You don't have to go to the hospital special surgery. It is a good idea to get a high quality EMG because that could, like in my case, it showed some early axonal regeneration at the 3 month mark. So it gave me peace of mind that my recovery may in fact happen. Even though I did not see anything for the first 3.5 months, it was completely dead as a doornail. This was a turning point for me. And I think the point that I'm trying to relay is get an EMG by a high volume place. I did it locally too, which was excellent. They do a lot of EMGs by a friend of mine, and see a hand surgeon that will navigate along with you. In my case, after the initial surgery was done very adeptly, I did follow then with Andrew Lovey, a friend of mine, who was able to guide me along with his mentor Alex Shin at the Mayo Clinic. So I was already thinking last, worst case scenario. I wasn't seeing any improvement after at least 3 months. But there it was, April 22nd, exactly 4 weeks after my EMG showed early axonal regeneration of the brachioradialis. Sure enough, my brachioradialis did start to fire again. So that means that the nerve was alive at the level of the injury. Now, whether or not it's going to go further down or if the pin is going to slow it down or block it, that was yet to be determined. There was no neuroma, so I knew that I should have a good chance. But until you start seeing things flex, you're not sure. But here, you want to see this. This is a very reassuring sign. The brachioradialis is the first muscle to start coming back, and it was, in my case, over 3.5 months after the initial injury. As you can see from my timeline, it's not like it just like dramatically took hold. I thought I was going to get the BR and then boom, it's going to get so strong. 2 weeks later, 3 weeks later, it was still very faint. I wasn't even sure if it was the BR, or if it was my biceps. I kept on thinking that. So you just have to be patient. And then you start looking in your mid forearm to see if anything else is starting to move. You can get an ultrasound if you like, but basically, things went very slowly. Remember, it's 2 centimeters away from your ECRL, the BR insertion. So you're not expected to get wrist extension for a while, even after your brachioradialis or your hammer function returns. And sure enough, a couple of weeks later, so it's essentially a month after the BR came back, I started to see the ECRL starting to fire. You can see May 29th, June 1st, June 11th. I started to see the ECRL. It was an eccentric type of, it wasn't lifting up straight, it was lifting up to the side. So I was convinced that I wasn't having ECRB. Of course, now the ECRB, eccentric cardioradialis brevis, takes off after the PIN, and I had a pin potentially decompression. So my case might have been a little off, but I had asymmetric lifting, and I think that's what you could expect after the brachioradialis. But of course, that this was very reassuring because even if I was not going to recover, at least I knew that maybe my tendon transfer wasn't going to have to be such a crazy, big one if I needed one. So again, BR, then the ECRL came. I had an opinion by Susan McKinnon, who was like a world-renowned person with a surgeon with the nerve, and she had said I should go right away for a pin decompression because my PIN was very dilated. I actually just emailed her, and she responded very kindly. And then I went with Dr. Andrew Levy and Alex Shin for pin decompression. This is so that the nerve would travel beyond the ECRB and ECRL and go to the other extension of the wrist. But my case was different, again, showing you the possible value of an ultrasound period. I did see another surgeon after that, and they said, they don't think that was related, but it gave me peace of mind having this decompression, which is a very minor surgery, which I'll show you. Basically, Dr. Lovey, as an outpatient procedure, opened up my arm and cut a few things and decompressed the PIN under the guidance and tutelage of his mentor, Dr. Shin. 10 days later, I thought I was a little better, but certainly 3 weeks later, it seemed that my wrist was more midline of raising it. And so at this point, I really felt like I had a chance at the road to recovery. Again, not everybody, most people will not have this pin decompression issue. I think it's probably coming back on its own. I can't tell for sure. But in my case, maybe it did help, and it certainly didn't hurt. 10 days later,
Here's the latest. August 4th.
You could see the hand.
My wrist,
Like,
lift up the hand. Pretty
I
much
could
a new thing over the
extend
last. I'm gonna go like
a little
this
bit.
month and a half.
The first two fingers.
Pretty
Not the other two
central.
fingers.
I don't have my thumb yet. I'm able to do bronchoscopies.
And,
I can lift up the wrist. Go like I can lift
this.
the first two
Is that
fingers.
middle
Chance
finger
a lot, but I
recovery
can't
here,
get
or
any
what?
stronger.
I hope you had a good time.
Still
At
a
least
long way to go, but
Mykonos
at least I have something.
feels very weird.
It's my
in
hand.
finger. Here's the
I can
latest.
lift my wrist,
You
which
can
is
see the hand. It's like
pretty much a new thing.
Here's
Here's
my
my
left
left
hand.
You can see I wasn't able to lift it off the table. That's the most I can get with the thumb.
So here's my left hand.
Right now.
Number
The
27.
index, see, I can do that on the table. Interestingly,
So here's my left
middle
hand.
is fine.
So the finger and the thumb, I mean, I'm a year out. I still don't feel really correct, but it's, I'm able to lift it up. My whole arm doesn't feel totally correct, but I mean, this is amazing. And the point of this story is, don't give up hope. It's a long journey. In my case, it took 4 months until I saw the brachioradialis, and then another month after that till I saw the ECRL, and I was able to lift up my wrist a little bit. And then I had another snafu and maybe needed a pin decompression. But, there are options. You have the nerve transfer, you have a tendon transfer. Make sure you follow with a surgeon who understands the nerves and who is patient and kind. And make sure you use these resources. You can contact me if you have questions. And ultimately things are going to work out. It's going to be a long journey, but things will work out.